The following podcast is part of a certified educational activity titled Chronic Spontaneous Urticaria from Diagnosis to Treatment, Unique Perspectives on Employing a Multidisciplinary and Patient-Centric Approach to Care, featuring Dr. Jonathan Bernstein from the University of Cincinnati College of Medicine and Bernstein Allergy Group and Bernstein Clinical Research Center in Cincinnati, Ohio, Dr. Paul Dagramji from Collegeville Family Practice and Ursinus College in Collegeville, Pennsylvania, and Ms. Corey Atkins, a patient of Dr. Bernstein. Access the entire activity and complete the post-test at www.peerview.com/KXJ860. Downloadable slides and practice aids are also available.
Paul, let's dive right in and get started. Can you tell me a little bit about the signs and symptoms of chronic spontaneous urticaria, and what clinical manifestations do you look for when you are seeing a patient with chronic hives?
Absolutely, absolutely. So chronic urticaria, well, first of all, let's just talk about urticaria in specific. It's a poorly understood and underestimated clinical condition that's characterized by a sudden onset of these itchy wheals, okay? This can happen with or without angioedema, which usually resolves, if it's the itchy wheals, which is the urticaria, it can resolve in 24 hours or less. So it can last maybe 15, 20 minutes, a half hour, a couple of hours, up to 24 hours. And the angioedema usually resolves within 3 days or so. A couple of things about these wheals, okay? These wheals, they have a central swelling of variable size, anywhere from several millimeters to several centimeters. They're almost invariably surrounded by some reflex erythema. There's a lot of itching. Some burning may occur, but there's a lot of itching that's going on with these. And again, as I said, it's fleeting in nature, with the skin returning to its normal appearance, usually within minutes to about a day or so. Now, angioedema, which is a much deeper condition of the skin, is sudden pronounced erythematous or skin-colored swelling of the lower dermis and subcutaneous or mucous membranes, and it's sometimes painful. It's more painful than it is itchy, but it can be itchy. And its resolution, again, is much slower, like it can take anywhere from hours to 3 days, 72 hours or so.
In terms of classification, what is your approach to discussing with patients how urticaria is classified?
Yeah, well, it can either be acute, which means it's lasting 6 weeks or less, or it can be chronic, which is more than 6 weeks or more. And this is how we kind of generally characterize it. One of the things also, Jonathan, is that these urticarial lesions can occur on any part of the body, whereas the angioedema has a typical location of being maybe in the mouth or throat, the tongue, the airways, and it can be on the genital areas and in the hands. But again, it can be classified as either acute, which is less than 6 weeks, or it can be chronic or continuous, which is more than 6 weeks.
Yeah, and that's again an arbitrary cut point, as you mentioned. We had changes in terminology. Previously, we used to think of this as chronic urticaria, and a common terminology was chronic idiopathic urticaria. But now we have replaced that with a terminology like chronic spontaneous urticaria that can be intermittent or persistent. And again, the other form of urticaria, which we used to call physical urticaria, we now refer to as chronic inducible urticaria. And again, this is hives that appear in response to different stimuli, such as heat, cold, exercise, pressure, sunlight, and so forth. The most common being a condition called dermatographism, which means to write on skin. And again, as you already pointed out, as we discussed, the fact that these lesions typically last longer than 6 weeks, that's what really differentiates chronic from acute. And it is important to make that distinction because the differential diagnosis and the underlying causes and the likelihood of finding a cause is much less in chronic spontaneous urticaria.
John, I also tell my patients that that, especially when they have the chronic type, that as the months and years go by, it can potentially get better, maybe even resolve spontaneously. But what do you tell your patients? Do you tell them, as far as expectation, that they can maybe expect that within several years or so that things will get better, maybe even resolve?
Yeah, and I think over time, typically we see, at least in studies, that hives may persist for 3 to 5 years, but they certainly can spontaneously remit in a year or 6 months. So it is variable, but on average, it tends to persist approximately a range of 1 to 5 years. What's of important to note is that if patients have an inducible component, that tends to have a more prolonged course where it actually lasts much longer. So if they have an inducible hive component, which is seen in about a third of patients, it tends to persist much longer, and the prognosis is not as good as chronic spontaneous urticaria without an inducible component. Now, with respect to angioedema, it's 40% of patients with chronic spontaneous urticaria, and it's important to differentiate types of angioedema that respond to antihistamines versus those that don't, because there are some that small percentage, very small population of patients who have a condition called hereditary angioedema, or even less common is acquired angioedema, which is caused by different mediators, predominantly bradykinin, which is a very potent dilator of blood vessels. And that's a totally different condition than what we're talking about today, which is urticaria with or without angioedema, which is histaminergic. It is a condition that is driven by histamine and other mediators released from cells, and we'll talk allergic cells like mast cells, and we'll be talking about that in a moment. So, Paul, what is your approach to the evaluation and diagnosis of chronic spontaneous urticaria?
The most important thing is to be a good clinician and do what we're trained to do in medical school and residency, and that's do a good history and physical. Look at the patient and start asking the appropriate questions. And that's very important, to exclude some other things that can be occurring in the differential diagnosis, or also to zero in on what kind of urticaria this could be, if in fact it is urticaria. So these are all important aspects of the first step in identifying what's going on with a patient with urticaria.
Yeah, and I would agree. I think there's a lot of points that one wants to consider. The time of onset of disease, as you mentioned earlier, the shape, size, frequency, duration, and distribution. Again, hives are typically evanescent. They come and go. They don't persist for longer than 24 hours. If you start seeing them lasting longer than 1 to 2 days, you think about things like urticaria vasculitis, which is a more severe form of hives. And we don't routinely recommend any kind of skin testing or to foods or aeroallergens. These are not related to hives. Unless a patient comes in and says, I eat this and I get hives, but that is something that is not what we see in chronic urticaria. So doing any kind of skin testing or specific IG testing to environmental allergens or foods routinely is not recommended. To do a lot of testing, if there's nothing in the history, is not recommended. But again, the guidelines would say that one could get a differential blood count, a sedimentation rate, and a CRP, and perhaps a thyroid stimulating hormone test to see if there's something going on, if there's nothing clear in the history. Everything else from thereafter would be based on the clinician's suspicion of if there's something in their history that you suspect, and one could, check things based on that history. But it's not, you don't want to just close your eyes and order a bunch of tests because it's been shown that it really doesn't change management and doesn't really help in terms of delineate what's going on with most of these patients. Is that how you approach these patients, Paul?
Yeah, generally, if I can get a good history and physical, find out that they have urticaria and suggest that it's probably idiopathic, treat the patient, get them better. If they're doing well, then there's nothing further that I need to do as far as workup. The more difficult ones, the ones that are chronic urticaria, the ones that don't seem to get better, the ones that seem to be sick, the ones that also have other systemic symptoms, those are the ones that I go on and start doing some testing.
but there are nice algorithms that are available for clinicians to follow in their process of evaluating patients who present with chronic urticaria with or without swelling. These are published in the guidelines, in the international guidelines, as well as the other very good review articles on chronic urticaria. Is this something you find useful, Paul?
Yes, I think it is. I think an algorithm is always a nice idea to have, and you have one in front of you here that's really important to go through. But fortunately, the great majority of cases tend to be a little bit on the easy side, urticaria, idiopathic, not much else going on, and the majority of the algorithms are not necessary. But it's important to have in front of us in the difficult patients that go on to be more involved than just the ordinary urticaria patients.
And I guess my perspective as a specialist who sees these patients, I get to see the more difficult cases, and we are seeing routinely these patients who present with vasculitis, who present with the acquired or the hereditary angioedema, or some of these other complex inducible forms of hives. So that's why I think it's important to be aware of these approaches, and because as you say, most cases can be fairly simple and uneventful, but some of them can be quite interesting and quite challenging. Would you like to discuss how you approach your patients? What is the first thing you do with a patient who comes in and you've gone through this exhaustive history and you don't think there's any specific cause, or you don't think there's any need for additional testing? How would you start this patient off in terms of treatment?
Yeah, well, fortunately, the initial recommendation is something relatively simple, which is a second-generation H1 antihistamine. So these second-generation ones, there are 4 or 5 different ones, like fexofenadine and cetirizine and levocetirizine. These are relatively available even over the counter without a prescription. And they, in dosages that are normal dosages in most people, can do quite well. But sometimes if it doesn't do well at the normal dosages, we can increase to higher dosages, like up to 3 or 4 times the normal dose, like let's say using cetirizine at 10 milligrams. If that doesn't help, push it all the way up to 40 milligrams. That's what I use in a lot of my patients, Jonathan, and for a lot of them it does quite well.
Yeah, and I think that you'll probably see a good response in up to 40% of patients. They will respond up to step 2, up to 4 times the dose of antihistamines, and which we call step 2 therapy. What's amazing to me is that you got to be very careful. You got to tell patients when you increase their antihistamines up to 4 times that this is really consensus recommendations by guidelines, because pharmacists are not aware of this, and they go to the pharmacist and they fill their prescription, and the pharmacist says, well, this is too high of a dose, you shouldn't be taking this much. And we really have to educate our patients and clinicians that it is a safe treatment for patients with hives, adults and children with urticaria, and this is a consensus recommendation. Again, all of these medicines bind histamine type 1 receptors very well. Some are better tolerated. Some people tolerate one versus the other better, but they all have good antihistaminic activity. What we see then, there is also the American US guidelines, which also may recommend adding on to that treatment using H2 blockers, which block histamine type 2 receptors. These are drugs like famotidine or cimetidine, which are now available, or adding on a drug that blocks leukotriene receptors. The evidence supporting those medicines is not as great, but they still may help in a subset of patients and are safe to use. Although there is a boxed warning now on Montelukast that we have to educate our patients about with depression and intrusive thoughts, but most patients tolerate these very well. This is what we do as well, similar to you.
One of the things, Jonathan, that I did not hear you talk about was corticosteroids. Does that enter into the algorithm at all in our treatment of patients with urticaria or even angioedema?
Well, that's a very good question, and both guidelines do give some latitude to using short courses of corticosteroids, especially in someone who is very severe and is miserable, until you can get them started on these other therapies and give those treatments time to take effect. So there is some latitude to use corticosteroids, but not to use it as a chronic treatment or to continuously, when a patient goes on steroids, they get better, and they come back 2 weeks later and the hives are back, and giving them steroids again and repeating this process cyclically over time. That will result in a lot of side effects over time, and there are much better approaches for treatment. But you are correct. Short courses of corticosteroids can be used in circumstances to get the hives under control until these other therapies can really keep things controlled. I'd be interested in your thought about using first-generation antihistamines in your patients with chronic hives.
Well, sometimes they'll just go to it, Jonathan. They'll just say, I'm going to take diphenhydramine because it works a lot better. I mean, they take it, get it over the counter, they try it, and it seems to work better. And if it does without drowsiness, I have no problem with it.
So I think I think if you use it properly, if you dose it at nighttime, try not to dose them in patients who are doing heavy machinery or climbing up on ladders, or very old people who might be more susceptible to the cognitive side effects and the motor coordination side effects associated with first generation antihistamines. But we do use first generation or complex antihistamines. One is called doxepin, which is actually in the US guidelines step 3 therapy before omalizumab, although I think that most people these days are going towards omalizumab after high-dose second-generation antihistamines. This is an anti-Ig monoclonal antibody, which was approved in 2014, just when the US guidelines came out. And there have been several pivotal trials that demonstrated its effectiveness, phase 3 clinical trials, which the FDA needs to see in order to approve these drugs. And the Asteria 1 and Asteria 2 trials were efficacy and safety trials. It was a dose elevation or dose comparator trial versus placebo, and patients with chronic spontaneous urticaria remain symptomatic despite treatment with approved doses of H1 antihistamines. And then the glacial study was actually designed to study safety and efficacy of the omalizumab 300 milligram dose, which is versus placebo in patients who remain symptomatic despite using these higher doses of antihistamines, the 4 times the antihistamine doses, and they could also be on H2 blockers or a leukotriene modifying agent as well during that trial. And this is just showing some of the data from Asteria 1. The primary endpoint was at week 12, and basically they were looking at mean weekly itch severity scores, and they also then looked at this study. Patients were discontinued after the 24-week period, and there was a follow-up period for an additional 16 weeks. And you can see after stopping it, many of these patients started to regress, and the hives came back and started approaching baseline. Never made it to baseline, but started approaching baseline. Again, a short study. What was interesting to see is that there was a rapid onset of activity after the first injection. Many patients had reduction in their mean weekly itch severity within the first 4 weeks. This is just showing some of the change from baseline percent reduction in mean weekly hive count scores from the Asteria study. And again, both doses showed significant reductions in the number of hives compared to the placebo. And this was also similar data that was seen in the Asteria 2 studies. Week 12, a significant percentage of patients, 36% of patients on omalizumab had no itch, no hives. 15% on the 150 milligram dose had no itch, no hives, whereas 9% of active controls had no hives or itch. So it was a significant difference, even at, and it was seemed to be dose responsive up to the 300 milligram dose. So this is just illustrating the effects of omalizumab on concomitant angioedema, which tends to be a little bit more difficult to treat, but one can see compared to placebo that the angioedema burden days per week were less on omalizumab compared to placebo. The median time to first recurrence of angioedema was 57 to 63 days compared to less than 5 days in the placebo, and angioedema-free days, both Asteria 1 and Asteria 2, and in the glacial studies were significantly greater compared to the placebo. So these are other endpoints that were looked at in patients with angioedema. Now, what about the impact of omalizumab on patient-reported outcomes in chronic spontaneous urticaria? This is results from a randomized study. It's called the Extend Chronic Idiopathic Urticaria Study. You can see that there was a significant reduction in the mean ISI score in patients receiving omalizumab compared to placebo. There's good separation showing reduction in anxiety. Other parameters were also looked at: work impairment scores, activity impairment scores, and a similar improvement with omalizumab was seen compared to placebo, and for both of these different measurements. And what if the patient is still experiencing symptoms? What's left for us to do? Do we throw up our hands and go home? Well, of course not. There's many other treatments. Paul, do you ever see patients coming in with hives who are taking cyclosporin? Is that anything you want to comment on?
Yeah, very, very few, but I have seen some patients that are really refractory to treatment. You can't identify any source, and it's idiopathic, and there's nothing. I mean, you've used antihistamines, you've piled them on, you've used leukotrienes, you've used steroids, and then eventually you see the allergist treating the patient with cyclosporin, or sometimes even other medications as well, just like you said, the biologics. So it can happen, but this is something which I stand on the sidelines and watch.
Yeah, and I think that from a primary care perspective, obviously you take care of all the hypertension, all the kidney disease, and these are the patients that we have to be very careful if we select these patients not to mess that up, because these are side effects of cyclosporin, and of course they can also affect their lipids and their cholesterol, so we have to be conscious of that. So it's important we work together with the primary care doctors in management of these patients. But of course we can see the patients who would be a poor candidate for cyclosporin, but there are especially younger patients who don't respond to omalizumab, patients who don't have these comorbidities. This might be a viable option. So there are a number of other emergent therapies. As we can see that not all patients, not 100% patients, even though a good percentage of patients respond to omalizumab, there's still patients who are refractory and need additional therapies. And there's some emerging therapies. One is called ligelizumab, which is actually completed studies and hopefully will be available in the near future. And again, this is a drug that is binds also. It works similar to omalizumab, but it has a higher affinity for IgE. So it seems to have a much stronger affinity, and therefore might last longer or be more effective. So so it is a modification of the same drug, but has some interesting properties that and the data thus far looks very promising of this drug being a nice adjunct to the management of patients with chronic urticaria unresponsive to high-dose H1 antihistamines. The phase 2b trial was a dose response curve, and again, that data showed that it was effective, and actually was interesting because it compared it to omalizumab and showed that showed even greater activity compared to omalizumab. And it's currently being evaluated in 2 phase 3 clinical trials called Pearl 1 and Pearl 2. You don't usually see active comparators like this in clinical trials where they actually use a drug that's like omalizumab, but it was quite interesting to see in this curve the percentage of patients with response was greater than the active comparator, omalizumab. The other data that they looked at was a number of different endpoints: weekly hives, weekly itch, weekly urticaria, looking at the severity score of zeros. And one can see that all of these endpoints favored ligelizumab over omalizumab. They all shifted to the right. Building on our previous discussion, Dr. Dagramji and I will now be joined by a patient from my practice, and we will take a closer look at some of the practical considerations when it comes to personalizing the care of patients with chronic spontaneous urticaria. Please welcome Ms. Corey Atkins. Corey, thank you so much for joining us.
Absolutely. Thanks for having me. I'm glad to be here.
Can you please tell us about your journey with chronic spontaneous urticaria?
Sure. I first had hives about 17 years ago. I was pregnant with my daughter, and all of a sudden I had some itchy wheals on my arm, and they grew. I had never had hives before, so I wasn't aware what it was, and they were very itchy. And within a matter of 10 minutes or so, it was very hard for me to breathe. And I called my husband. He was at work, and he said, "You might want to get to the emergency room." And so I drove myself there, and by the time I had gotten to our local hospital, I could barely breathe. The hives were spread all over my arms, up my ears, just everywhere. And that was my first occurrence with hives. And from that day to about 2 years ago, I had hives 1 to 4 times a month with those same occurrences. It'd start off small. Sometimes it'd be behind my ear. I'd start to feel a hive. Sometimes it'd be on my arm. Now, if I could catch it in time, I could take a Benadryl or something like that, then the anaphylaxis wouldn't come. But if I didn't, then my EpiPen was out and I was ready to go.
So again, this is a little atypical for chronic urticaria. For chronic urticaria, we don't see a lot of the systemic symptoms where people are going to need an EpiPen. But as we talked about, sometimes that does happen. There's some other clinical symptoms that can occur. So what treatment options have you tried for your chronic urticaria, and what has been your experience with specific therapies?
Sure. So when I first, like I said, many years ago, I went to my family doctor, and he suggested starting on Zyrtec, which I did. And it worked as far as I didn't have hives every day, so that's kind of atypical. But I didn't have hives every day or even on a set schedule. So it was kind of, I started with 1, and then like you had said earlier in the meet, up to 4. So at the time that I met Dr. Bernstein, I was doing 4 Zyrtec, 2 Zantac, 1 Singulair, sometimes steroids if I had a bad reaction. Always had my EpiPen with me, always had Benadryl with me just in case. I tried to stay away from the Benadryl. It made me very drowsy, kind of made me puny the next couple of days. But I started low and then went up as high as I could get.
Okay, and then in your experience, what kinds of interactions did you have with your care providers, positive, negative, that could help other patients who are dealing with similar challenges?
So with my family doctor, he was unfamiliar with a lot of the urticaria signs and symptoms, and so he sent me to an allergist here locally, and they did the allergy test on my back, and then again on my arms, and everything showed up. And so she didn't really know what to do. And she told me, basically just keep Benadryl with me. So, which, I think for a typical hives patient, it would have been okay. But for me, it didn't work for me. The medications, while I was taking them every day, I didn't have hives every day. So when the hives would come, I would need immediate action. And it took me, I met Dr. Bernstein 2 years ago, so it took me 15 years of dealing with hives monthly, and sometimes, up to 4 or 5 times a month before I found what really worked for me.
And you bring up some good points. Not only did the family medicine not have a lot of experience with the hives, the allergist you went to was doing things that really weren't adhering to guidelines either. So we have a job. Paul and I have a real challenge to educate our colleagues about the proper approach to chronic urticaria, both primary care and specialty. So what impact did having chronic spontaneous urticaria have on your family, work, and social life?
Because it was so spontaneous, it was hard to plan most anything. I had to keep my EpiPen with me. I also had to have a supply of Benadryl with me just in case. And because, like I said, it was spontaneous, then it didn't really matter where I was, or I tried to live life how I could, because I couldn't just stay at home all day. I had a job and, activities I had to do. I had a young daughter, so, we had to go and do, and so I couldn't be held back too much. But when the hives did come, I tried to be very relaxed. And, if you're out in public, it's hard to do that. So sometimes I would go out to my car if I was at work, and this would happen. Sometimes I would go out to my car and try to be very calm, because I know as soon as my heart starts racing, it's harder for me to breathe, and that takes a whole cycle itself. So it did impact quite a bit. I tried not to let it as much as I could, but because of its spontaneous nature, it happens when it happens.
So do you have any advice or perspectives on non-medical interventions like support groups to manage chronic spontaneous urticaria?
I actually joined a group on Facebook, of all places, because not a lot of people deal with this, that I have in my personal life. Not a lot of people deal with it, and so it's hard for people to understand, kind of what I'm going through. But I found people through Facebook that I talk to almost on a daily basis. I try to encourage them, and we talk about treatment plans and things that they've done, things that I've done, and so it's made it nice that we can have a conversation, that I can talk to people who know what I'm going through. It's helpful, when I have family and friends who empathize but don't really understand.
Yeah, and so what has actually been something that's finally controlled your hives, and what you describe where you are right now and how you've been doing lately?
So I started on a Xolair shot. It's been two and a half years about. I take it every 4 weeks, and since beginning that therapy, I've had 0 outbreaks, 0 hives, no anaphylaxis. It has been a welcome change to making sure I have all of my pills and my shot, and just the unknown factor of when it'll come. It's not a pleasant experience either. So the Xolair has really given me my peace of mind back. Really given me my life back. Really, I haven't had to come, do the Benadryl and then be drowsy and, spend the next couple of days just kind of vegged out, I guess. But it's been wonderful. I had the side effects. I don't have hardly any. Every once in a while I'll get a little bit tired for a day, but that's it. And I'll take the tiredness. It's been wonderful.
Oh, well, thank you for this experience. I think it does help us to, when we really hear from the patient's perspective, to really appreciate the journey. I mean, this is quite a burden. You've spent 15 years trying to find some kind of treatment. 15 years ago, we didn't have omalizumab. So this is something that's really only been around for the past 6 years. So it's very gratifying to know that you're finally, at least your quality of life is improved, and that you are able to maintain good control of this condition. So I guess this kind of comes to the conclusion of our discussion, and we can probably summarize some of the main takeaway points. Would you like to summarize some of the main takeaway points, Paul, from the perspective of the primary care doctor?
Sure. First of all, urticaria, chronic spontaneous urticaria, occurs in up to 5% of our population. It's pretty common. We see it often enough in our practice. And generally and initially, it's not that difficult to identify and treat. Just get a good history and physical and make sure that it is urticaria and not anything else. Make sure that the patient does not have any systemic symptoms or systemic problems like potentially anaphylaxis, and look for the possibility that there's also angioedema. Once identified, see if there's any triggering factors, see if anything is bringing these conditions on that you can eliminate as the initial treatment. And if that doesn't take place, or if that doesn't help, then adding a second generation antihistamine is the way to go. But there's an algorithm of how to treat our patients to get them to be completely symptom free. And after a certain amount of treatments that we try in primary care, then if things don't work out too well, we refer patients to people like you, Jonathan, who can take it from there and get the patient to be as good as Corey has gone in her journey with treating her urticaria.
And I think those are very salient points. Thank you for that. I do think that once we have to appreciate the complexity of urticaria. Unfortunately, the treatments tend to be a little bit easier than the underlying pathogenesis and understanding the mechanisms of this condition. So we still have a long way to go to understand better what is driving this condition, how do we modify it, how do we effectively control it. Some of the newer therapies that we have available, such as omalizumab, has really improved our gaps in treatment. We're learning more about urticaria as a result of these new therapies. It has helped many patients, but there's still room to grow. There's still a lot of room for improvement. We still have patients who aren't always controlled by these therapies, and some of the existing therapies like cyclosporin, although they may be effective, do have toxicity and have to be used judiciously with patients. But all in all, we have to listen to our patients. We have to try to help them understand what's going on. Patients all too often come in saying, can't you test me for foods? Can't you test me for allergens? Can't you do this? We have to educate them about what is the appropriate approach to these conditions, so we don't waste healthcare dollars and we target their management appropriately. That ends our discussion for today. Thank you again, Paul and Corey, for your insights.
My pleasure to be here.
Thank you for having me.
We hope you found the activity informative and useful to your practice, and encourage you to participate in the other modules that are part of this curriculum. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KXJ860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.